Hello, everybody, and I'd like to welcome you all to our celebration of International Women's Day 2022. This is a global day where we celebrate the social, economic, cultural, and political achievements of women throughout the world. The day also marks a call to action for accelerating gender parity. And just a little bit about International Women's Day. The first gathering was actually held in 1911 and actually was supported by over 1 million people in Europe. But prior to this, we had the Socialist Party in America, the suffragettes in the UK, and also other groups which were campaigning for women's equality over the years. And significant advances have occurred in that time frame. One of the things now about gender equality is it's not just really women who support gender equality. Men have come on board and become allies also for gender equality. And in fact, governments, companies, are challenged now by voters, by their customers, by their clients, and by their investors on their equality, diversity, and inclusion figures and how they support EDI in the world today. And the world now expects inclusivity, and expectations are rising all the time. However, although much has been done, there's still much to do, as the slogan goes. And in the late 1800s and 1900s, women activists fought hard for equality. And the focus was largely on securing the right to vote and also equal pay for equal work. And even though we've made a lot of advances, these two issues are still actually very topical in today's world. Even in this country now, we're still looking at our figures, the figures of women we have in government, and the gender pay gap does still exist. And so the theme for International Women's Day this year is Break the Bias. This is a theme that tasks us all to raise awareness against bias, to take action for equality, and to be aware of the significant impact that bias has on women's equality, both conscious and unconscious bias. And we need to recognize it and call it out. And, if we think about what's happening in the world today, if we look at, Afghanistan, where very modest increases in the quality of life for women were implemented over recent years. And those modest advances were taken away overnight when the Taliban moved back. And so, we can't take anything for granted. And it's up to us to call out bias and gender inequality where it exists. And so on that note, we're delighted to have our two speakers here today, Professor Karina Butler and Dr. Patricia Scanlan, two wonderful role models for women in medicine, to talk about their inspirational careers to date in paediatrics and how they've tackled and dealt with bias in the workplace. And so I leave it there and ask you to take off, Dervla.
That's great. Thank you so much, Marguerite, for the lovely introduction. And it's my absolute pleasure to be here today representing the UCD School of Medicine EDI Committee and to have this opportunity to chat to not one, but two fantastic female leaders, both of whom are UCD graduates. So we're delighted to welcome Professor Karina Butler and Dr. Trish Scanlan, as Marguerite said, who are here with us today to celebrate International Women's Day. So Professor Butler is a specialist consultant in paediatrics and infectious disease at Children's Health Ireland, and she is also chair of NIAC, which is the National Immunisation Advisory Committee, as well as a member of NPHET. Her clinical research has focused on the prevention and management of HIV in children and adolescents, leading to global recognition, particularly in the area of prevention of mother-to-child transmission, and her outstanding achievements in establishing the Rainbow Clinic as a national centre for HIV medicine in children and a national referral centre for paediatric infectious diseases. As chair of NIAC, she is committed to the prevention of infectious diseases using safe and effective vaccines, And this experience has also been extremely relevant of late during the COVID-19 pandemic and has fed into her role as a member of NPHET. Dr. Scanlan is a paediatric oncologist at Dar es Salaam, Tanzania, and is also currently interim director of global health at Children's Health Ireland. After relocating to Tanzania in 2007 to work on the Children's Oncology Ward at the Ocean Road Cancer Institute, Dr. Scanlan spearheaded the creation of a national strategy for paediatric oncology and established the National Paediatric Oncology Centre at the Muhimbili National Hospital, which really is an incredible achievement. And importantly, care for these very sick children has been transformed under her guidance, and we look forward to hearing more about that shortly. As Marguerite alluded to, this year's theme for International Women's Day is Breaking the Bias. And as such, I'm very much looking forward to discussing Professor Butler's and Dr. Scanlan's views on gender bias in the workplace, any challenges that they as women may have encountered in their careers thus far, and any advice that they may have for others. We're so delighted that both of you were available to come and talk to us today. And I'd also like to take this opportunity to welcome all of the students that we have with us here today who are joining us, and to please, ask you to use this fantastic opportunity to pose any questions that you may have for Karina or for Trish in the chat box, because we'll have time for a little Q&A session towards the end of this session, which is a really important aspect. So without further ado, I'd like to kick off, and I'd like to start really by asking both Karina and Trish to give us a brief overview of their career to date and really what drew you to paediatrics as a specialty. And Karina, I might come to you first on that one.
Okay, first of all, can I thank you and all the organisers for inviting us here. In fact, I really feel very humbled to be asked to talk to a group like this and on this issue. All I have is a life experience. I don't think I have the right answers by any way, but at least we can talk about things. So how did I get into medicine, or why? In reflecting about it, I really see, if you like, my career to date as a journey of 3 pandemics, in the sense that when I was born back in the 50s, we were in the middle of the polio pandemic. And as it happened, I got polio at the time and ended up in a fever hospital, Cherry Orchard, for 6 months, during which time, think about the COVID time, parents weren't allowed visit. You handed the baby in at the door and they were sent home to collect them sometime later. They were allowed intermittent visits, and they were described by mother to me looking through the window. And so, that harks back. There was no medicine in my family, but there was that background of information about infectious diseases. My mother always had surgical textbooks in the house. I don't know why. I think she was a woman who didn't have the opportunities that women of my generation and subsequent generations had, in that college wasn't really an option for her, because I think she would have made an incredible investigator. But as it was, she was a person who certainly gave me her philosophy in life, which was, to every problem there is a solution. I went to UCD, and that was a wonderful experience in time. We only had 1 year in Belfield, and then the rest was in Earlsford Terrace. So it was almost like being back at school again. You had a class and you made great friends. And then on to medicine, and I had done a lot of babysitting, interestingly, and people kept telling me you should be a pediatrician. I wasn't sure at all at the time, but then did my internship and went and did pediatrics, wasn't sure, went back to adult medicine, and then I knew, because going back into the adult world from pediatrics, I just knew it wasn't for me. I couldn't wait to get back to pediatrics. And so from there, I did a couple of years in Ireland, then went to the States. And that was something else. And this is a message for everybody, because when you go at that stage, particularly, we often have that bit of a chip on our shoulder that everywhere else was better. And when I went, having had a couple of years training here, it was amazing, because we realized actually we were far advanced in our training than many of the contemporaries. And in fact, Irish graduates have always done so well everywhere they've gone and are really appreciated. So then it was about specialization. And I couldn't decide what part of the body I wanted to specialize in. I wanted to do everything. And that's why infectious disease, and the sense of the detective work and putting the pieces together. And in fact, my co-panelist, Trish, when finishing working with me, she gave me a gift, which was a picture of someone doing a jigsaw, essentially of broken bits of glass and putting them together. And she said that's what infectious disease was like. It was searching, listening, hearing the story, getting the pieces, getting the clues and putting it together. And that's why I end up in ID. So in ID, and I don't want to go on too long, but in ID, that came to, if you like, the maturation of my medical career. And it was the time of the second pandemic. And that was in the 1980s when HIV hit the world. And we knew so little about it. And there was such fear. And we had no treatments. And yet now we're at a stage where living with HIV, for someone who takes their treatment, their prognosis, their life expectancy is even longer than those who don't, probably because they're in better medical care throughout. And so fast forwarding then another 20, 30 years or so to retirement, and what happens? COVID comes along. So that was my life story, and essentially in 3 pandemics. And I'll have to stop there because I could go on for hours.
No, that's fantastic. Thank you, Karina. I think that's a really interesting way to put it, to say that, you know, you can break it down into 3 pandemics, which is quite incredible, really, when you think about it. And Trish, I'd like to pose the same question to you, perhaps a brief overview of your career to date, and indeed what drew you also to paediatrics.
Thanks, Dervla. Well, first of all, I would also like to echo what Karina has said about being invited here. I'm very honoured to be here, and I also am super grateful to UCD. Since I've left UCD, I don't feel like I've left, because so many times the faculty has reached out and been supportive. So it is very, very much appreciated to like always be thought of and included in such things. So that's really amazing. My story is quite simple. I again did my medical schooling in UCD, and did pretty much all of my specialty training in paediatrics in Ireland. I knew from the very beginning I wanted to do paediatrics. There was no doubt in my mind. I had, as you do in Ireland, you jump around various different hospitals in various different cities, which gave me a special draw for the city of Galway. And I was also super, super fortunate to spend 6 months working with Karina. I would say that anyone who has been a specialist registrar for her has said the same thing, that it really is like formative. You learn to be as well, you try to aspire to be as good a doctor as she is, and I certainly have learned an awful lot from her in that way. As a medical student, I spent 2 months, as many people do, in Africa. I went to Kenya, and I loved that time. And I think at that point, as happens to a few of us, is that Africa gets under your skin, and it's almost impossible to forget it. When I was choosing what subspecialty I was going to do, I did think about doing infectious diseases, and actually kind of went a little bit down that road, and had done some HIV courses and training. But I kind of felt, you know, a lot of people come to the continent of Africa and their specialty is infectious diseases. And I kind of thought perhaps there was room for another type of specialization. And my other love, having been in St. John's ward in Crumlin a number of times, was paediatric oncology. Even though it's a really tough specialization, and it's often quite sad, it can also be just an incredible experience, because you get to know the children and the families so well, and they let you in at kind of their most vulnerable. And it's a real privilege and an honor to be there with families when they're struggling and they look to you for support. And if you feel you can offer that, I really found that really rewarding. And I found that I possibly made the right decision, because my very first week when I chose to come here, someone asked me, "Oh, you're a doctor, HIV, TB, or malaria?" And I said, "Well, I thought it was cancer, actually." So that stopped them in their tracks. So when I left, basically during my specialty training, I took a year out to do a master's in international health, and as part of that, I I basically looked around for where I would do my thesis, and I found a link with Tanzania, with Salaam and with Ocean Road. And so that's how I first ended up in Tanzania. And I really, I was here for only 6 weeks, and then I decided I would come back. The reason I decided to come back was because there was a group of kids who'd been offered treatment for free, and the doctors and nurses had been offered a little training, and they had moved survival from less than 10% to more than 70% by themselves. And for me, that was proof of concept that there was hope here, even though for all the other conditions, the children were not doing well. But it wasn't for the lack of care by the teams, it was that they didn't have access to services. And I kind of felt, you know, if you arrive in a situation and you're in that really happy circumstance that you're like, what's missing here? I actually have those skills. It's really amazing, but I think I do, and I think I can help. So I left, and then I came back, and I intended being here for a year, but that was nearly 16 years ago. So I have been here for quite a long time, and in that time have moved the children from the cancer hospital to the university hospital, built a ward, built a hostel, realized that one service and one hospital is not enough. So we now have the National Children's Cancer Network. We have 11 sites. We're hoping to get to 30 sites. Not all of them will have to treat, but sites that interact and can move children rapidly to where the care is, so that no child has more than a 4-hour journey in order to receive the care they urgently need. And one of the main premises is that everything we do is free of charge for the children. And we work within the hospital system, the government hospital system. We're not doing a parallel service. That's it, I think.
That's fantastic. Thank you, Trish. It's such an incredible story. And I think, you know, when I was doing a bit of background reading on this, it really struck me how, you know, really after 10 years or within 10 years of graduating from UCD, you had moved to Tanzania and indeed established this National Children's Oncology Centre. So it really is an incredible achievement. And you know, no pressure to the students tuning in here today, but it's incredible to hear that story, and to hear really what inspired you. So I guess would it be safe to say that the initial trip to Tanzania that you would have taken as part of your medical degree here in UCD was really kind of what drove you to fall in love and to move there?
Yeah, I mean, I loved that 9 weeks that I spent in Kenya. I really loved that. And then actually just after my SHO years, I took another 1.5 years out, and I went to Ethiopia with Goal, and I spent a year in Vietnam. So I kind of was always back and forth, trying to find what would be the best use of my experience and time. And it just happened when I arrived here that it just seemed to all fit. You get a sense that just something just clicks. And the other really big problem I had was I'd get to a point where I'd say, well, there's nothing more I can do here. And then someone would arrive and say, oh, what is it you need to get over that? I have that. And I was like, oh God, we better do it. So, and that sort of has happened for 15 years. So, yeah.
Well, it sounds like it's all going quite well.
Well, I mean, thankfully, I mean, the great thing is the inspiring. If you're asking what inspires me, and I'm sure maybe Karina has a similar thing, is the children. I always say if I'm having a bad day, it's because I haven't spent enough time with the children on the ward, because no matter how sick they are, they always have time to cheer you up. They're amazing. They're really, really amazing.
That's fantastic. Thank you, Trish. And Karina, I might come back to you then and talk to you about, you know, the last couple of months or years, really, because I think you've been absolutely an inspiration for many women across Ireland during the third pandemic that you talked about, the COVID-19 pandemic, at a time really where the female voice was notably absent amongst key decision makers. And I was wondering if you could perhaps talk to your experience on, firstly, perhaps your role with NIAC and then being appointed chair last year, as well as your membership of NPHET as a female. And, you know, did you ever find it perhaps intimidating being so outnumbered by males? And do you have any tips for females who might find themselves in similar situations?
Well, you know, you asked, did I feel intimidated being outnumbered by males? And I think when I reflect on that, you know, as a question, the interesting thing was I wasn't outnumbered by males. if we look at NPHET, at least in its final iteration, it was 2-to-1 female to male, and NIAC, sorry, that was NPHET had an excess of females over males, and NIAC is over 2-to-1 females to male. So I suppose that immediately gives a question in the sense of, if there were so many females on NPHET and all very prominent, I think it's just their voices were there, but maybe they're not always heard in the context of really being at that leadership role. It's just something I was thinking about today, because like we had, and there were 32 members in NPHET at the end, and 19 of them were female. We had Mary Favier, who is the ICGP lead, and she certainly had a lot of media. We had Mary Horgan, who's the first woman president of the RCPI, and in fact, the first person to serve 2 terms. So there are a lot of people who are really breaking through whatever that ceiling is that is perceived. But it's interesting that everyone's perception is that there wasn't such a strong female voice there. So I think that's something for us to reflect on. And I don't have the answer, but I think that that's interesting. So how did I come to be in NIAC? Basically, NIAC started back in the 80s, when it was just at that time, there were concerns about vaccination and maybe contraindications to it. And so the idea was to have a place that would look at it, that would make best practice recommendations, that would increase the uptake of vaccination, and that would be able to list what maybe side effects were, contraindications were. So it was about getting safe, secure, trusted information in order to provide good advice to the government. And also, 2 of the main things were to educate healthcare professionals, but also to educate the public. And that sense of beginning to really information sharing, distilling it, and being in partnership with the public as well. So since I came back to Ireland, which was in the early 90s, I've been involved in NIAC in one way or another. And it was really just in the last few years before COVID that I had asked to be chair of NIAC. So I was expecting NIAC to go on in its quiet way, working in the background, not getting too much attention until really the COVID pandemic hit, and then everything changed. It has actually, I can't deny it's been a hugely stressful and time-consuming experience. It has been a hugely rewarding experience. It has been a great team. And yes, the females do outnumber the males right across the board in NIAC. But you know what? I'd never even thought of it that way until looking over for this today. Because really everybody is there doing their best together. And maybe that says something about where we've come from in the past. The collaborations have been fantastic. And I think what it has done has also strengthened the recognition for collaboration across different agencies, so that we're not working in silos, so that the interaction between, for example, NIAC and the College of Physicians and the HSE and the Department of Health have really all worked so hard and so collaboratively together. And a lot of that is really about that openness, the openness to accepting a phone call, giving a phone call, the personal connection. And although it's strange in this time of COVID, when we haven't been able to meet in person, in some ways, a lot of those connections have actually been strengthened, albeit through Zoom or whatever else. So it really has been an exceptional time, I know, for the country. In some ways, I feel incredibly privileged because I didn't experience lockdown in the way other people did, because I was going to the hospital to work and meeting people. And I think there were huge stresses, and I think that's going to be a burden on people going forward. It's going to take time to get over that. And I think we need to be very supportive of people, because everyone has handled that in different ways. But NIAC has been a really wonderful experience in terms of collaboration, and I hope has sort of succeeded in bringing that partnership with the public on board, sharing the information the way it is, the pros and cons, the uncertainties, the what we know, the what we don't know, but what our best assessment is. I won't say best guess, because it's not just guess, there's evidence and analysis, but there are huge uncertainties. So that has been some of the learning through NIAC, that we also have to learn how to deal with uncertainties as well.
That's great. Thanks, Karina. And it's yeah, it's fantastic to hear actually about that that positive experience and the collaborative efforts that of course we don't see, that's all going on behind the scenes, and such an impactful a committee that has had a major impact on all of our day-to-day lives over the last while. And I think, you know, in keeping with today's theme, it's actually, yeah, indeed great to hear that there are movements towards breaking this bias, if you like, and progressing forward in that scheme of things. And I guess in the spirit of this, I would like to ask you both about your views on gender bias. I know it's a very broad and a general question, but I think it's an important one in keeping with today. So your views on gender bias in the workplace. And, you know, I think it is something that many people in healthcare, academia and beyond might have experienced at some point or another. And so it's nice to take the opportunity today, I think, to talk about this and to have the conversation. So Trish, I might come to you first on this one, whether or not, first of all, what your views are on gender bias, and then, of course, what the landscape in Tanzania perhaps is like relative to Ireland.
So I have to say, I don't really feel qualified to talk about gender bias, because I've really been trying to think about it, and I don't feel that I've experienced anything significant that I could really, I've spoken to friends of mine, I've spoken to my folks. I really feel that from my childhood, and I feel kind of blessed about this, that I was always given the same opportunities that my brothers were given, and that other boys or girls and, you know, men or women were given all the way up through. I don't feel any of the jobs that I was given or not had anything to do with me as a woman. It was all kind of, you know, CV related or interview related. In Tanzania, it's kind of extraordinary here. When I got here, the national hospital, the biggest university hospital in the country, which is Muhimbili National Hospital, where I work, literally every head of department was a woman. Everyone, the head of the hospital, the medical director, the pediatric surgery, radiology, lab, everyone was a woman. And so Tanzania is quite progressive, I think, maybe harping back to its socialist roots. No, it's not the same today. It changes every few years, but the point being that there are a lot of very, very influential women in Tanzania in government and in maybe particularly in healthcare, maybe in other areas it's not quite so prevalent. But what I would say is it seems to be almost two-tiered. So if you're middle or upper class, if you have an education, you know, if you went to school, if you got the opportunity to go to university, then it seems here you were treated, boys and girls were treated equally. Whereas if you're poor, it's very different. You know, and we see it on the ward. We see it when a mother has a child and they need to make a difficult decision. Like, for example, we tell them that we need to take, you know, the child has a cancer in their eye or in their kidney, and we need to take the eye or the kidney. There are women who cannot make that decision because they will not be welcome home if they do it without getting either the father or the grandfather's permission. And so we have lost children because of that, because they have to travel back to the village, get a permission because they don't all have phones, and then come back. So it's very, very interesting, and I think it's poverty related. So, you know, in kind of the circle I would run in, they could teach the world about equality, but there's a lot to learn from a poverty level.
That's very interesting, Trish. Thanks very much for the insight. And gosh, yeah, to have to travel all the way back home, that's incredible.
It's impossible, really. Impossible.
Say that again?
I said it's impossible, you know, to do things effectively. And that's part of why, you know, we're having the centres all around the country so that they don't have to make these difficult journeys and have these difficult decisions. You know, do they lose their family or their child? Because that's essentially the decision we're asking them to make.
Wow, yeah, that's incredible. Absolutely key. And Karina, I might ask you the same question, what perhaps your thoughts or views are on gender bias in the workplace, and if you have ever experienced anything or have any feel that bias in medicine or beyond even has or perhaps has not evolved over time?
Well, I was very interested to listen to Trish and saying how she never felt she had suffered gender bias. And I would identify with Trish in that. In my own personal situation, have I seen gender bias? I would put I've never suffered because of gender bias, or maybe just in one. I'll go through that. But and I suppose I come from a different time, because watching, reading in the ears last night and going back to the 70s, where it was a very different perception of things. But maybe again, it was the family that I was in, and the expectations was never anything different. It's a difficult one to think about. I think of my generation, and probably older than I, to a certain extent, we were blind to it. It's almost like someone who's colorblind. They don't know the colors, they don't see any difference. When you grew up in the 50s and 60s, there was a lot going on, and into the 70s, that we didn't see as being abnormal. Okay. So we were interns, and there were attractive interns, and you would have the various social occasions, and you didn't kind of think it as abnormal if some of our older male consultants seemed to want to dance a little bit closer than you were comfortable with. And so if you were strong, you learned how to strengthen your arms and keep that distance. But there probably were the more vulnerable who suffered in that. So, I mean, that was in the culture, or, you know, how you dealt with it. You learned how to, without even being conscious about it, you were dealing with that all of it, not all of the time, but it was there. In the workplace, in terms of career progression, no, there was no gender bias, except on one occasion when I went to interview, and it was not in this country, it was in the States. And I was interviewing with a head of department who happened to be very Italian and probably Sicilian. And when it came to talking about salaries, his response to me, well, you don't need a salary because your husband is working, kind of thing. And that's probably the only single time that I encountered frank gender bias. You are a woman, you are working, you should be in the home, you don't really need a salary. That was the one and only time. The one thing, thinking about it, we have to think about gender bias isn't just by men against women. Probably in the small things, it's actually more pervasive from women towards other women, in the sense of within the hospital setting, you would see it as junior hospital doctors or that, where other females, other women, be they nurses, would take the advice from the registrar who happened to be male over the female. That has disappeared over the years, but it certainly was there. And to a certain extent, at least looking at Twitter yesterday, it's certainly people are still experiencing that. So we have to be conscious that those kind of biases are not just from male to female. I think it raises the wider consideration of all of our biases. And Marguerite mentioned this, our unconscious biases, and the biases that we as women have and aren't effective in terms of whether it is the person of a different ethnicity, whether it is the person who is maybe more obese, whether it is the person who does something differently than ourselves, not just are they male or female. So I suppose what we should be trying to do is to grow in awareness of all of our unconscious biases, and trying to be reflective in ourselves as well as expecting that of others and trying to deal with it. So gender bias, I think the other thing that I do have to say that I think is pertinent is that both Trish and I are working in pediatrics. And pediatrics is notably a gentler environment and a more aware environment in those issues than I'm given to understand that the adult environment is. So I think, you know, both of us are coming from a somewhat similar perspective in this. And I think that may not necessarily be generalizable to the whole experience. And certainly then when you go beyond medicine into some of the other areas, such other professions, such as law or that, certainly I would say they are less aware than we are within the pediatric medical community, because that's actually the one that we know. And so what we're saying, I think, is probably a much better situation than many other of our female colleagues experience. I don't know if Trish would agree with that.
Yeah, I would totally agree. I was just going to say the very same thing. And there's a lot more women. Again, I think there's proportionally more women than men in pediatrics. So it's basically, it's an advertisement for anyone. We're very progressive. There's very few gender bias issues. You should definitely come and do pediatrics if you're doing medicine or nursing.
But you know, and I know that in years past, I have articulated this to myself, if not to others. And I suppose it reflects that unconscious awareness of gender biases there. At one stage, I would worry that pediatrics was going to become an all-female specialty, because I felt if it became an all-female specialty, it would lose some of the credibility that it has when it has both males and females there. And so I think that actually there is that level there. And in some other countries where it is an all-female specialty, particularly pediatrics and in obstetrics, or tend to be all-female specialties, they are certainly not regarded with the same level. And you do see it. You do see it in the economics of it. You see it in the payments as to, whether it's a pediatric specialty, but it also goes to sometimes the cognitive specialties versus those that are, if you like, the male hammer and chisel, traditionally type specialties. There is a lack of equality there, I suppose.
That's great. Thank you both. Some really excellent points there, I think. Overall, it's fantastic to hear that neither of you really have experienced any direct bias when it comes to career development, which is fantastic. And I think the take-home message is indeed that pediatrics is a wonderful specialty in that case. But
could I say one more thing on that? So basically, the one thing I would say is I'm very kind of almost uncomfortable because I haven't had any experience of gender bias, particularly in the workplace. But I do think what people like myself and Karina and other people who might be listening who might have a similar experiences, what you might do is you see young women and young men as well who are working with you or in the same department, that what you can do is be kind of on the lookout, like an advocate, to make sure that the system and the way you have been treated is maintained, and having like high standards all around you, and being kind of the gatekeepers and the advocates for the younger generation to make sure that you don't find anything else like that creeping in around it on your watch. And I think that that's been an important thing as we have built this service here, is to make sure that it's not like you're all right and you close your eyes. It's like you're all right and you make sure your environment is also safe. Yeah,
absolutely. I think that's an excellent point. And I guess, would it be okay to pick your brains then on asking, it doesn't necessarily have to do with bias, but if indeed there was a situation where, for example, medical students or younger professionals, in coming up their career, if they do encounter bias or indeed something else in the workplace that makes them uncomfortable, how would you advise, anyone who might be afraid to speak up or to actually address that? Would you have any advice as to how to deal with that? Because, I think it crosses many different domains, and it's a challenging one that, only comes with time, I imagine. But what would your advice on that be?
So I think the most important thing is, if something like that is happening, is that you find someone that you trust, that you can speak to about it, and then hopefully they can take the kind of the emotion out of it and rationally analyze it and find out, was it a misunderstanding? Was it a true issue that needs to be addressed? Was it a once-off? Not that that's not important, but or was it something that's systematic that needs to be changed at a system level rather than an individual level? But if you find an advocate who you can trust, and you can allow them to explore what you've experienced kind of in a safe environment, and allow them to guide you through the best, rather than, it's not always safe or easy to kind of, you know, approach someone head on. But I would hope that there's always allies where you work. I think it would be a very sad situation if you found yourself in a work environment where you had no allies who would be able to speak up. I think people, I know I'm a strong, sometimes annoying person, but I hope that I can use that strength to kind of, so that people, like, I always have the door open here to anyone who wants to come and kind of discuss any issues they have. Sometimes with me, if I'm overly, there's a word here called Kali, which means kind of cross and grumpy. Sometimes I am, and I, you know, I allow people to come and kind of, you know, check me as well. But I think it's important to have an open environment, so that people feel safe to come and speak about something.
Completely
I don't
agree.
think I could put it any better than Trish has articulated. It was exactly what I was going to say. The first thing is really not to keep things to yourself, but to share them with someone that is trusted, and hopefully maybe a trusted senior mentor that can sort of help, as Trish says, take the emotion and look at it objectively and analyze it and then see it for what it is. And most of all, to try and make sure that there isn't something systematic going on and to help through it. But I think allowing things like that accumulate and feeling put down or feeling less valued, because that really is the important thing. It is how we value each other and that we feel valued. I think it's very important to share it. So it does become particularly difficult if it's someone who in general is afraid to speak up for themselves or has already got issues in that. So I think that's where you have to be preemptively looking out for it, rather than always waiting for someone to come to you, and not, as senior people, not to be afraid to approach people and reach out and sort of, you know, is everything okay? There are different ways of doing it. It's not kind of tell me what's going wrong. You know, you can find the moment, and just to have that openness so that people then know. And you might say to someone, look, do you want to come and talk about something? And they'll say no, but you can say, look, I'm here, I'm available. And then if they, at least they know there's an open door.
Absolutely. I think a lot of the time that in itself is a massive help, and having, you know, good mentors, good advisors that are there in the pipeline to be able to go to in these instances, I think really is key.
That's right. And I'd also like to say that I do think that leadership is important. You know, it's again echoing what Karina has said, but like as the director here, I do feel that no matter what happens and no matter what the interaction is, I'm responsible for it. You know, certainly maybe not, you know, in the moment, but I'm responsible for maintaining the quality of relationships and the quality of, you know, the work that's done. And in the same way, I'm responsible for the atmosphere at work. And if I allow something to continue that shouldn't, so that's what we can do as, you know, the stronger women who aren't afraid to speak out. It is our responsibility, and as Karina said, it's not the responsibility of the vulnerable to come and talk to us if they don't feel able. I mean, yes, we would like them to, but maybe they can't always. It is our responsibility to look for them as well.
Absolutely. Thanks, Trish. And I've no doubt that your team are in excellent hands. Perfect. So I think in the interest of time, we might switch over to the open Q&A session. Thank you both very much for the fantastic discussion, and I think we can continue it now. I'll hand over to Fiona, who's going to moderate the Q&A. So if anybody has questions, please feel free to post them in the chat, and Fiona will post them directly to Karina and Trish. Thank you.
Yeah. Hi, everyone. That was really interesting. Gosh, I suppose it's a real positive message going out to people today that the bias that you've experienced is not so bad at the moment, but in terms of gender. There's a question in from Marguerite for Professor Butler. What do you think the major impact of the COVID pandemic has had on women in medicine? And also, with so many women in NPHET, why was it 4 out of 5 men appearing on the news every night? I think that's a fair enough question.
Yeah, it is a fair enough question. Well, the reason that the 4 or 5 appeared on the news every night, and it wasn't always the 4 men, in fact. Sometimes Lorraine, the head of the HPRA was there, or Lorraine Doherty from HPSC, or indeed myself at times was there. It's just that at the moment our CMO happens to be a male, as does the deputy who has the experience and the responsibility in this area. So, you know, I think ultimately we will get to a place where we won't be always looking for things to be, we won't have to be looking to show that there are same number of males and females and everything, where we really want the people who are the most experienced in the room at the time. And for example, Professor Nolan, who was doing the modeling, he really was the best voice at the time. So I think that's why that particular grouping. But in terms of if you were to look at all of the media interventions related to it, I think you would probably find there were as many by, for example, Mary Favier, Mary Horgan, myself, as there would have been, maybe not quite as many as by the CMO or that, but they were there. But it's a fair question. As to what impact has it had on women in medicine, I think, again, it's been difficult on women and men in medicine, and particularly on the front lines. The one thing we haven't talked about through all of this in gender equality, and it is, I suppose, not the elephant in the room, but the issue is work-life balance and family, and it still happens. Forget the workplace. In terms of division of labor within the home, it's still a situation in probably most settings that the woman takes on the day-to-day management of the household in addition to the work, whereas the men are a little bit protected from that. They're more involved, but even with the most involved, it's still the bottom line often falls with the woman. So I think having to deal with that, and then the concerns of going to work and dealing with COVID and what has to be done, has had a huge impact on them. I think it's only going to take time to see what the long lasting, if there are, whether we'll see more people leaving, nurses who have burnt out from being on the front lines every day. I just don't have the answer completely as to where it's all going to end up yet. Thank you.
Yeah, I think the burnout in particular is maybe more impacting the females if they're trying to manage it all.
Children being home from school in isolation.
Their children.
Yeah.
And I have a flexible job, so I can't imagine the stress of having sick children and trying to manage a clinical load.
Now it is changing, and you will see. You know, my son is in medicine as well. He's off this week. The child is sick. Mom is going back to work again. You know, it is, the load is being shared more, but still in the overall, it still falls very much more heavily on the shoulders of the women.
Do you think, I often think, you know, equal maternity leave and paternity leave, where the men have to take the paternity leave and assume that from the outset of the child's life would be a massive bonus to society. Not sharing the maternity leave for the woman, but giving men prolonged paternity leave would be, I think, a big step forward to equalise the platform.
It's an interesting concept, because there's no doubt, and certainly I've seen it happen even recently, where timeouts for maternity leave, and particularly within, more so outside of medicine, but in medicine as well, but definitely outside of medicine, can compromise your career prospects and limit your development, whereas the men have the more flexibility in not doing that. But having come from an era when there was no maternity leave, and we had 2 weeks of vacation and 2 weeks of sick leave, and that was your maternity leave. That was in the States when I was going through that stage. Where we are now is significantly better, but no, it hasn't removed. It does mean that there are significant disadvantages to women who are going through having maybe 2 or 3 children and then ending up with serial maternity leaves. particularly in some of the other professions, even more so than in medicine. Medicine has, you know, brought flexibility in a little bit more with flexible training schemes and that, but there's still, look, there is a price to pay. I mean, one of the learnings should be that we can't have it all, and we shouldn't try to have it all. You know, we went from the 60s, where if a woman got married, she had to stop work, literally, to the 70s, which was sort of when I was, if you like, coming into the workforce, and the early 80s, where we were beginning to believe we can have it all. And then there does come now to where we are, where we should realize that for men and women equally, we can't have it all. You know,
yeah,
it has to come to an equipoise for both. I don't know if I'm articulating that very well.
No, it's like about a healthy balance, isn't it?
But for the woman to be trying to run a full-time career at top notch and take the home on at the same level that was done by the woman in the 50s who was at home, that's not feasible.
No.
Is it feasible to have a full-time career and to have a good work-life balance? If you've got good partnership and good equality in the home, that's feasible.
Yeah, I agree. Actually, one of the positive stories I heard from one of the Nordic countries was a colleague was going for promotion, and he didn't get the promotion because he didn't take his paternity leave. And I was like, that's the change, I think, you know, making the balance so that a woman who's of childbearing age isn't discriminated against if she was to have, you know, if she was going for a job interview. I think that would be brilliant. There's more questions coming in here. The gender pay gap is higher in female heavy specialties, GP side, palliative care, public health medicine. Do you think that women are aware of this when they make their career choices? That's a great question.
No, I don't. I think in Ireland, certainly not. I don't think it is. Certainly, it wasn't something I don't think I or my colleagues thought about in terms of choosing specialties. I'm sure Trish can talk to that. She clearly didn't think about it anyway. In other countries, maybe they have to be more focused. People are coming out with high college loans. That certainly influences. But there is a significant, but I don't think it's male female. I think it's specialty and procedure orientated. There's less respect for cognitive specialties. For example, psychiatry, you don't do any procedure. In pediatrics, there's a lot of non-interventional care given. In infectious disease, it's a cognitive specialty. Whereas if you're doing something like you've got a procedure, like you're doing a catheterization, or you're doing a hip aspirate, or you're doing something, those things have generally been reimbursed more highly. In a way, the state is trying to level that playing field in what they're doing, in terms of taking people, and you can go on an A contract, and that is the salary level. But traditionally, there have been differences there. Yeah.
Trisha, do you have any comments to the gender pay gap? Oh, we haven't lost her, shall we? We can't see her there. Never mind.
Her internet seemed a little unstable.
She might have got kicked out there. There was a point there from Elizabeth. It would be interesting to see how much parental leave is taken by men, and parental leave be seen as the norm for both parents. And absolutely, this is a huge action point for our Athena Swan, because it's very apparent that men in the School of Medicine don't take that much parental leave. And the awareness that they are entitled to take it, as well as the women are entitled to take parental leave, was not there actually in the community within the school. I know it's more difficult in the clinical setting.
That's often factored in by virtue of the disparities in pay between men and women. Because if there's parental leave, and some of the parental leave is non-salaried, you are going to, within a unit, a family unit, it may be economically better for the person who is the lower paid to take the more parental leave. So that, and I have seen that happen the other way around, where it's the man who takes it because he happens to have the lower paid job. It's not always just about male, female. It can be driven by economic necessity.
Yeah, true. Gerald has a point there. Thanks for a brilliant seminar, fascinating to listen to. I was struck by comments about how there was a feeling that PEDS is an area that is a particularly good place to work when speaking about bias, equality, etc. While that is great for PEDS, does it not point to an issue across other areas? And isn't it so disappointing in this day and age that it is potentially a factor women take into account when making career choices?
Well, I think as both Trish and I said, that was one of the caveats we wanted to state, is that our experience isn't necessarily generalizable. I don't know that it actually influences career choices in that way, but maybe it does for some. It was more about, and I think you heard it from Trish and from myself, it was more about being in the environment with children. Hadn't even realized there might be differences in the work environment at that level.
I have a question. We kind of alluded to it at the start when we were talking. I was like, where can we do better? You know, if we seem to have we're progressing very well in the male-female gender domain, but where do we need to improve in medicine?
It's a good question. I think it is about being aware of our biases, our unconscious biases, about the differences that might be gender related, but also about all those others. It's about, as I say, when I described it in the beginning, that maybe in the 70s and that for many of us, now there were those who had their eyes open, but many of us went through sort of blinkered, accepting things as the norm. So I think by highlighting it, even by things like doing this, it's making people stop and think and look again, and then trying to make sure that the environment that they're working in is one where everybody is equally respected and valued, be it whether they're male or female, or be it whether they are disabled or whether they are different color, or any of those issues that, if we're honest, we all sometimes have to recognize that we do have biases. I think Trish has just come back.
She has, she just came out. She was avoiding the questions.
Trish, we'll give you the hard questions.
I think she might have dropped out again. She must be struggling with her.
I'm back.
You're back, Trish.
I'm so sorry.
Trish,
I'm so sorry.
What can we do to do better?
Wait, I just had, we were almost about to wrap up, Trish. The last question I had there, to Karina, might just put it to you as well. Where can we do better, in your opinion?
I think the main thing is, you know, just because you're secure, and it's what we were saying before, just because you're secure and, you know, like I personally, as I say, have not experienced anything, you shouldn't feel comfortable, you know. I know you shouldn't work in, so I think it's possibly some of that. So I think where to do better is that, you know, just because you're all right doesn't mean that everyone around you is, and we should be more vigilant. We should be always looking to see what we can intervene and who we can support. You know, if we get up the ladder a bit, it's not pulling it up behind us, but like maybe letting it down a bit lower, and you know, helping everyone.
I think that's a great note to hand over to Marguerite. Oh, Karina, go ahead.
Yeah, no, just thinking about it there. I think where we can do better, and maybe where we're really at fault, is sometimes we don't value ourselves enough, and that we are willing to do more for less. And I don't mean just monetarily, I mean time-wise, giving it more. I just think that sometimes we don't shout as loud or ask as clearly or articulate our needs as well as sometimes maybe the men are quite happy to do. And sometimes then that can be taken advantage of.
That's really powerful advice. Marguerite, I'm going to pass over to you. Yes, value ourselves.
Okay, so I'm just going to wrap up, and I'd like to thank everybody for attending and listening today. And of course, a special word of thanks to Karina and Trish for a really very honest and a very inspiring interview that's given us all a lot to think about. And I think you'll agree that they've both showed us that we both need to, we all need to have confidence in our abilities and to find our own voice on the road to success. So I hope you all enjoyed it as much as I do. We're looking forward to welcoming you to and involving you in more School of Medicine EDI initiatives. And just to remind you that this session was recorded and we hope to have it up on our EDI website soon and encourage you to visit that website. So to everybody, I say happy International Women's Day. Enjoy the rest of the day and goodbye. Thank you.
Thank you. Thank you.
Thank you so much, folks.
Thanks, everyone.